Welcome to Pathology Central Race in Medicine, Keloids Beyond the Pale. I begin with a pun, but this is a very serious topic because we're going to do a deep dive into the literature and we're going to uncover misinformation, lies, plagiarism, poor study design, and structural racism. So, why keloids? Those of you who've watched my other videos know that I am the pathology course director at Duke University School of Medicine, and that for my students, I've been doing a deep dive into the literature for each entity for which our textbook, Robbins Basic Pathology, 10th edition, mentions a disparity based on socially defined race. And keloids show up in week 2 of our course. And I was quite casual about this because I thought there's really going to be nothing to say. I learned about African descent and keloids when I was a medical student 20 years ago. I'm a soft tissue pathologist. It's in our textbook. Trying to do a deep dive on this would be like doing a deep dive on why water is wet or why ice is cold. I was very wrong, as you will see. Let's begin by briefly discussing what is a keloid. So for most of us, if we have a minor trauma, so a cut, a scrape, a piercing, our myofibroblasts proliferate, our fibroblasts lay down collagen, our skin reepithelializes, and we have perhaps a faint trace of a reckless past, but nothing significant to recall our physical trauma. But for other individuals, that same minor trauma can cause an exuberant and excessive repair process. And this is referred to as a keloid from the Greek kela. Here's an example. This is an individual who was in an industrial accident with multiple small projectiles, and each wound became this protuberant mass. It's composed primarily of collagen. Now these can be not only disfiguring, but they can also be painful if, for example, a bra strap or a belt crosses it. Now for our students at Duke, we've been providing images that show lesions not only in the typical lightly pigmented skin, which you see in almost all textbooks and online, but we're being very careful to show it also in darkly pigmented skin. If you look at your textbooks, you'll see almost all of the lesions are in lightly pigmented skin with the rationale that, but they show up better. And we're doing our students a disservice because this means that they won't be able to diagnose this in their patients with darker skin. It occurred to me I should do the converse. Take lesions that were more commonly shown in darkly pigmented skin and also show them in lightly pigmented skin. And I thought it'd be very challenging to find images of keloids in lightly pigmented skin because we all know keloids are more common in individuals of African descent. Well, this is a teachable moment because remember that just because something is more common in one population doesn't mean it's non-existent in another population. So take, for example, cystic fibrosis. 94% of the patients in the United States are of European descent. But that means that 6% are not of European descent. And we ignore that percentage at our and our patients' peril. So when I did a search for keloids, I found it's awfully easy to find these in lightly pigmented skin. This is an image we'll be using in the next edition of Robbins and Kumar Basic Pathology. And it's important to show the different skin types because lesions that appear erythematous in lightly pigmented skin are often hyperpigmented in darker skin. Here's a classic ear-piercing keloid from dermnet.nz.org. As a pathologist, I must show you a histologic image. Here we see the overlying epidermis. We have some scattered inflammatory cells, and then deep in the dermis, these deep, thick collagen bundles. On higher magnification, you can see the glassy appearance of these bands, and this is what we see in keloids. All right, now it's time for our deep dive. So as part of my work in revising Robbins Basic Pathology, I've been working with a colleague, Dr. Joseph Graves Jr., who's an evolutionary biology professor at North Carolina A&T State University. It is the largest historically black university in the country. And our collaboration is based on understanding the evolutionary biology behind some of these disparities to be sure that we're being scientifically accurate. And after working through the literature on keloids, I emailed the editor in charge of this chapter and said, I think you should remove this aspect of African descent. And he replied by giving me a quotation from UpToDate saying that keloids have been reported in 5 to 16% of individuals of Hispanic and African ancestry. Now, because of my work for my students, not only have I read UpToDate, which is always a great place to start, but I'd actually also read Reference 5 by Robles and Berg. Let's take a look at that. So here is our reference. We have two sentences which we're going to dissect. The first one refers to a very dramatic statistic that keloids are approximately 15 times more common in dark-skinned individuals compared with whites. And then we have an incidence of keloids in blacks and Hispanics varying from 4.5 to 16%. So UpToDate is referring to a review article, and somehow we've lost 0.5% just in that transition. So let's now look at these two references that Robles and Berg are using. One is Brissett for the 15 times higher, and the other is Akkosh. And we're going to begin with Akkosh. So this is an actual original research article, but it's not looking at Hispanics or blacks. It is looking at earlobe keloids in individuals in Turkey. So they once more do their research, but refer to this 4.5 to 16%. And here are the three references they use. So let's take a look at those now. So we have Kosman from 61, Kunin from 64, and Uluwasanmi from 1974. So this is reference number 9 by Kosman. This is also a research article in which these surgeons looked at patients in their clinic who had keloids. And they found that of their patients, 74% of them were considered Negro and 20% were white. Ordinarily, I would use terms like African American and European American, but the definition of white has varied with time, and it's not clear whether white would refer to what we now consider to be European American. For example, the Irish, Italians, and Jewish populations were not always considered white in this country. And they found about a 3-to-1 difference between these two populations. Now, we don't have a denominator, and we don't know what their catchment area was. If this is in the Harlem area, then most of their patients may have been of African descent. And if most of your patients are of African descent, it would make sense that most of your population who has these would be of African descent. So we'll set that aside for now. Now, they refer to two articles here. Both of them are from 1931 from a dermatologic meeting in Strasbourg. The first paper they mention is from Nagli. It's a population study where they found that 4.5% of school children and 13.3% of Swiss adults had keloids. They have a similar article from that same meeting where Staub reports 16% of adult Congolese workers had keloids. Now, before we go any further, because we are going to look at these articles themselves, just look at these two figures. So 13.3% and 16%. Is this clinically significant? Is this something that you think, oh my gosh, I have to be sure that generations and generations of physicians know that keloids are more common in Africans? I would say no. Okay, and just to point out here, the 4.5%, this is in children. As we grow older, we have more opportunities to fall and injure ourselves and get multiple piercings and tattoos, so that accounts for the disparity between the two ages. Now, because at this point I trust nothing in the literature, I have to pull this article. It is in French. Fortunately, I lived in Paris for a year, so I'm able to read these. So this is looking at statistical, experimental, and biological research on keloids. This was done in Bern, Switzerland. And you can see, in fact, that 4.5% of écoliers, or school children, had keloids compared to 13.3 adults. Now, at the same meeting, a physician named Monsieur Lespin from Belgium gave his talk on tattoos and keloids on Africans in Congo. And during the discussion after his presentation, Monsieur Staub, also from Belgium, who was in Congo, stood up and presented some data. Now, this is like what you see at your typical meeting. Someone comes up to the podium and instead of asking a question, instead provides their own view on things and some data. As far as I can see, these data were never published and have not been peer-reviewed. What he describes is looking at mine workers in Congo. And I'd just like to take a moment for us to reflect. He is a Belgian physician. We're talking about 1930s Congo. colonial situation with tremendous exploitation and racism. And he is looking at adult mine workers. So just please do reflect on that for a moment. And what he found after looking at about 1,200 adults was that about 16% of them had keloids, some due to vaccination or in vaccination sites, some of them on the site of burns. So once more, we have our 16%. And think now, that figure that we see in UpToDate, that 5 to 16%, this is where that 16% comes from. It comes from 1931, non-peer-reviewed literature from a meeting. All right, that finishes just looking at that one. We're deep down the rabbit hole. So that finishes our first reference in the paper by Robles, in which we have this reported 5 to 16%. Here's the second reference, which is part of that collection. This is from an individual named Kunin, who is a 6-year medical student at the University of Cape Town, so a very privileged individual. Thanks to the staff of the South African Medical Journal for scanning and emailing me these articles. So he talks about race as being a possible etiologic agent, and once again mentions it being more common in the colored races. He mentions here Negroes, Hindus, Malayans. Once more, you'll see Hispanics are not appearing in this reference. And he gives various ratios here: 2 to 1, 19 to 1, 14 to 1, 9 to 1. And so we don't have a denominator for this. And once more, you have to be careful because you have to look at who is your study population. If you're doing the study in Africa, where most of your study subjects are African and very few of them are European, you're going to see a lot more keloids in Africans than in Europeans. It's simple math. So we'll take a look at that in a moment. Just also want to draw your attention to this where he talks about the skin of blacks versus whites, and we're going to address that when we talk more about structural racism. I simply would like to say that here we can see this deeply pigmented, swarthy, oily skin compared to the light, thin, dry skin. So can we guess what type of skin Kunin might be having and why he might be supporting this idea that these disfiguring lesions are more common in individuals with dark skin? So I wanted to take a look at his references. Many of them are from the 40s. And my goal was to find references that were from the United States. Because as I said, if we're looking in Africa, then the ratios aren't particularly useful. So let's find a paper from the United States that this ratio may have been based on. So here's one from 1942 in New York. This is an original research study. They looked at 80 cases of keloids. And you can see here that once more in their discussion, they talk about Negroes, Hindus, and Malayans having keloids. Lots of discussion here. But what they found was that in their 80 cases, there were only 3 colored patients. But this can easily be explained by the fact that very few colored patients apply for admission to our skin department, and that white patients are more likely to seek advice and treatment for keloids. So we have a good data set here that we could look at, but we have explained it away because it does not fit in with what we want to see. So finally, the last paper that Akosh describes is this one by Oluwasanmi, who shows up again in Brissett's paper. And this is one that's done in Nigeria. This physician found that 5.8% of his population had keloids. So no ratio. We're not seeing, I don't know where the 4.5% or 5% is coming from. We have 5.8% here. And if we had just this paper and we were comparing it to the Swiss paper by Nagli, we'd say, well, you know, Swiss adults, 13.3% of them have keloids, but only 5.8% of Africans. So keloids are much more common in Europeans and Africans. So you can see the problem. This brings us to Brissett. So this is the second paper that was mentioned in the section I showed you by Robles. What you can see here is, again, we have this ratio, this number here, 5 and 15%. These two papers are by Oluwasanmi, who is looking at Nigeria. So this percentage, this is not based on a denominator which is looking at all the population. We don't know exactly what this denominator is. The third article is a 1973 Atlas of Birth Defects, and as a physician, I'm not sure why birth defects would be so connected with keloids, which we see in terms of injury. I went as far as to put this in my online shopping basket, and I thought, no, that was a bridge too far even for me. So let's look at this statement here, because this speaks to the 15 times more likely to occur in darker-skinned individuals. So this statistic shows up in a total of 4 papers in the literature that I was able to identify, and this paper from 2001 is the origin of that statement. And what Brissett and Sherris say is that in a review of 175 cases of keloids from various races, Al-Hadi and Sevantathara found that keloids were 15 times more likely to occur in darker-skinned individuals. So let's pull that paper by Al-Hadi, shall we? So this is from 1969. It was a study that was performed in Malaysia, and this is what their results showed. In this selective series, the relatively fair-skinned Chinese appear to be slightly more prone to keloids than the dark-skinned Indians and Malays. And I did the math and found the ratio was about 2 to 3 times more likely for the fair skin versus the dark skin. So let's compare that now to what Brissett has said. Here we have 15 times more likely in darker skinned. So not only is the number wrong, 15 versus 2 to 3, but the arrow is pointing in the wrong direction. And this misinformation, as I mentioned, is in 3 additional papers and is still in the literature. So Al-Hadi, though they're doing the study in Malaysia, are still addressing color as far as keloid predisposition. And they refer to 2 papers, Ketlowski and Allen, where they are now saying a ratio from 2 to 1 to 14 to 1. Well, let's look at this. I pulled the paper by Ketlowski. He doesn't mention incidence at all, so that can't be where either of these come from. And this paper by Allen is from 1954, and it's based on the Bantu. So the Bantu, if you're looking simply at Africans, they would have a fairly high ratio. So what? So say we've looked at this and we have found, in fact, that the literature is wrong. Does it matter? I mean, you know, does this matter clinically? Does it matter to us as physicians? Does it matter to us as patients? How does this contribute to systemic racism? And does it? And I would say it does, because we are taking a lesion that is disfiguring and we are associating it with dark skin. So here we can see Ketlowski, who I referenced earlier. This is a 1953 paper where he refers to what is associated with keloids. The deeply pigmented, swarthy, oily skin is more prone to keloid formation than is the light, thin, and dry skin. And we have another reference here to the dark, oily, heavy skin than the fair-skinned peoples. So we have this association of darkness with something that's just really not particularly appealing. Now, you've seen this deeply pigmented, swarthy, oily skin before. We saw that from this 1964 discussion by Kunin, who clearly has exactly plagiarized from Dr. Ketlowski, never thinking it would be discovered, but not counting on Dayrup. Now, I'd like to make an aside about albinism, because part of the discussion has been that keloids are not seen in lightly pigmented people because people who suffer from albinisms rarely develop keloids. Now, this is from a paper by Gao from 2005. I took it with a grain of salt because he still is quoting the 15 times greater incidence in dark-skinned versus light-skinned. And in fact, he did not provide a reference for this statement. It's just taken as assumed fact, like so much about keloids. But there is an excellent reference from 2015 in which a population-based study was performed. These researchers went into rural Africa and actually looked at people. They described 8.5% of patients with what they call normal pigmentation, I call wild type, as compared to 7.8% in patients with albinism. So no statistically significant difference. So you can put that misinformation to bed as well. So is any of this clinically relevant, right? How is it helping? Is it just a fact that we teach students so they can do well on their boards? Does this make a difference, knowing or believing that one population is more prone to keloids than another? Although we've clearly just shown that that's not the case. Here's a very interesting article from 1980 from an African-American plastic surgeon who found in his practice that African-Americans were not more prone to keloids. And he also makes the point, he does elective plastic surgery, and many patients were reluctant to get surgery because they feared a disfiguring keloid. And he said, you know, you can just look at the patient's skin, because by the time they come in, most of us have had some sort of abrasion or piercing or laceration or surgery. And if you have a tendency to get a keloid, you'll have a keloid. So I don't need to look at the color of your skin to project whether you'll have a keloid. I just need to look at your skin. And this brings us to the important point, right? What you need to do as a physician is to examine the patient. Take that time. And then regarding geographic ancestry, to be thinking, well, this patient, derived from this population, that's not nearly as important as taking a good family history. We do know that keloids can have a family predilection. So what I'm going to ask is, do your brothers and sisters have keloids? Your cousins, your parents, your aunts and uncles, your grandparents? That's going to tell me everything I need to know about this individual's geographic background. And not just for keloids. This also will, you should do this for all diseases, and we'll also look at cultural differences. So perhaps this particular group has a food or a drink or a medication or a folk practice that, or something that they do that is unique to them. And then you will find out by finding out what their family does. Okay, so this is the important thing right here. Here are my references. I've gone through them in detail. I'd like to thank you very much. For those of you who did make it to the end of this talk, would you please put a comment down below, because I find it really gratifying. Anyone who wants can shoot me an email, and I will send you a copy of the disparities document for yourself or to share, and please do check out my website. And as always, have a great day, and thank you for your work and your interest.